Okay, for the last topic on pharmacology that I will be discussing, we have pancreatic hormones and anti-diabetic agents. In this topic, we will be discussing the pharmacological agents that can alter how the body produces and also secretes different pancreatic hormones and also agents that can alter blood sugar. Those are called as anti-diabetic agents. This chapter is divided into the following subtopics, beginning with discussing the pancreas. Pancreas because this is a specialized endocrine hormone responsible for secreting different endocrine hormones. Next, we have insulin. Next is glucagon. We also have discussion on diabetes mellitus, like the different categories, and finally, medications that can be used in the management of that metabolic disorder. So first stop, guys, let's begin discussing the pancreas. As I've said, ang pancreas ay specialized endocrine gland that can secrete different types of hormones or endocrine hormones. Endocrine pancreas consists of 1 million islets of Langerhans that are interspersed throughout the pancreatic gland. And these islets of Langerhans to ento, Langerhans, have different cell types. Those are the alpha, beta, delta, G, and F cells. Please note that these cell types produce different products or produce different hormones. In particular, ang dominant dito are the alpha and beta cells, which are comprised of 20 and 75% of the islet mass respectively. In particular, for alpha cells, ang pinoproduce niyang hormone ay glucagon, kay alpha cells ay glucagon, and beta cells naman, we have the hormone insulin. Okay, so again, alpha cells, glucagon, beta cells, insulin. So sa topic natin for this morning, we will focus on these hormones, glucagon and insulin, because they have direct effects on blood sugar and therefore sa diabetes mellitus. Okay? Moreover, your knowledge in biochemistry will help you out in understanding the effects of these hormones based on what you had learned before in that subject. So the following are the effects of the hormones being produced by the islets of the pancreas. Number one, we have insulin. Insulin is responsible for storage and anabolic effects in the body. So remember, pag sinabi nating anabolic effect or anabolism, insulin is the hormone responsible for building up certain compounds that are necessary for storage, And often, insulin is the hormone that is being secreted by pancreas, especially during, what do you think, based on your stock knowledge, during fasted state or fed state? Sa tingin nyo, pag ikaw ba ay gutom or busog? Very good, during fed state. That's right. So ang insulin, ito ay isang hormone na sinesekret tuwing tayo ay busog. Remember in biochem, pag tayo ay busog, there's too much glucose. Kaya ang goal ng body through insulin secretion is itago ang sobra. And that is anabolism, right? So for example, the excess glucose would be converted into larger compound like glycogen. Okay? So pwede siya maging glycogen through glycogenesis, right? And this will be stored, for instance, in the liver and also in the muscles. In addition, this also promotes formation of triacylglycerols, okay? Triacylglycerols or triglycerides. And these triglycerides are principally being stored in the adipocytes or in the adipose cells. Kaya nakakapagtago tayo ng excess glucose. So yan ang effects ng insulin. More on anabolic siya. Okay? Next hormone we have amylin. Okay, amylin. Amylin has several effects like modulation of appetite. In particular, amylin promotes satiety effect. Okay? Again, ang amylin, it promote satiety effect. So anong ibig sabihin natin ng satiety? Pag sinabi natin satiety, ito yung nafe-feel natin eventually pag marami na tayong kinakain. That is feeling of pagkabusog. Okay, nabubusog tayo. Kung walang amylin, imagine niyo, never natin mafe-feel na puno na ang tiyan natin, lamon pa rin tayo ng lamon. So thanks to amylin, merong signal sa atin na, huy, tama na, busog ka na dapat. Too much na ang glucose sa katawan mo. Tama na, wag ka nang kumain. Okay? So yan yung amylin. It modulates appetite or it promotes satiety effect. Okay? Next, gastric emptying also related pa rin yan sa satiety effect, glucagon, and finally, insulin secretion. Next, third hormone. Can you follow so far? Okay, next we have glucagon. Note class that glucagon is the antagonist of insulin, meaning to say the effects of glucagon ay kabaliktaran ng insulin. So remember, for insulin, it has anabolic effect. Ang glucagon naman, catabolic effect. Okay, so catabolic hormone siya. With that being said, glucagon provides glucose necessary for survival. That's why isa siyang hyperglycemic hormone. Okay? That's why isa siyang hyperglycemic hormone which mobilizes glycogen stores. When we say mobilizes glycogen stores, it can degrade, it can catabolize glycogen into simpler forms. Ano ba ang simplest form ng glycogen? Di ba ang simple form niya ay glucose. Okay? Kaya magagamit natin siya for energy. Overall, ang glucagon during fasting state or fasted state, pag gutom tayo, siya ang nasa-secrete ng alpha cells of the Langerhans. Okay? Next, we have somatostatin. Ito yung mga miscellaneous hormones. Somatostatins are universal inhibitors of secretory cells. For gastrin naman, this is a mediator of hydrochloric acid secretion. And finally, the small proteins called pancreatic peptides, although mechanisms of action are not yet clarified. Okay? Altogether, class, these are the different hormone products by the islets of Langerhans. With this being stated, please note that we will have an emphasis. We will have an emphasis on insulin and also glucagon. And in some extent, ma-encounter natin ang amylin. Pero bandang dulo na siya. With insulin and glucagon, these have direct effects on blood glucose and thus related to the topic diabetes mellitus. Kaya i-discuss natin yung dalawang yan, starting with insulin. Ulitin natin, insulin is the one being secreted during fed state, okay, pag tayo ay busog. Now, let me tell you that we have certain stimuli on how insulin is being secreted by the beta pancreatic cells. For example, in this figure, isipin natin na yung drawing, this represents a beta cell, okay? A beta cell of the islets of Langerhans. Okay? And then, i-discuss natin dito kung ano ang nangyayari that would induce insulin release. Okay? That would induce insulin release. So we have the following stimulants. Basically, ang stimulants are glucose, of course, major stimulus siya para masekret ang insulin. And then we also have others or miscellaneous like mannose, amino acids that are glucogenic, okay? Glucogenic amino acids, like for instance, leucine and arginine, okay? Like leucine and arginine. Also, we have glucagon-like peptide, okay? Glucagon-like peptide or GLP-1. Ang glucagon-like peptide is an example of an incretin, okay? So it is an example of an incretin together with GIP, okay? Together with GIP. So ulitin natin, for GLP or glucagon-like peptide and also GIP or glucose insulinotropic peptide, both are incretins. Okay? Both are incretins. Later, madidiscuss natin ang effects ng incretins. Aside from that, possible stimuli also, we have glucagon, possible, okay, in some cases, and also we have cholecystokinin and then vagal activity. So since marami tayo mga stimulants ng insulin release by the beta cells, we will emphasize glucose here kasi siya ang major stimulus. Kaya i-discuss natin in this figure yung stimulant na glucose. So how does that happen? How does that happen? Suppose, kumain tayo, di ba? Fed ay kumain. So pag tayo ay kumain, expected na marami tayong glucose that freely circulates in the body. And in that case, pag marami tayong glucose na nasi-circulate, pwede siya makarating sa beta cells ng pancreas. Makakapasok ang glucose molecules will enter the beta cell via a specialized transporter, and that transporter is called the GLUT2 or glucose transporter 2. Okay, again, that is being uptaken by the glucose transporter 2. Kaya you can see in the figure na ang glucose ay makakapasok sa loob ng beta cell. So far, nasusundan? Naintindihan yung pagpasok ng glucose sa beta cell? Okay. Mind you that glucose transporter 2 is limited to certain organs or certain cells of the body at isa doon ang beta cells. Pero hindi lahat meron ito. Kaya hindi lahat ng cells kayang kumuha ng glucose. Okay? So again, balik tayo. Glucose transporter 2 is responsible for the uptake of glucose. Now, pag ang glucose ay nasa loob na ng cytosol ng beta cell, you learned in biochemistry that there are enzymes found in the cytosol responsible for the aerobic respiration of glucose. In other words, pag nakapasok sa cytosol ang glucose, mag-undergo siya ng glycolysis, wherein magiging pyruvate ang glucose, and then ang pyruvate ay magiging acetyl-CoA, and finally, makakapag-produce ang acetyl-CoA ng adenosine triphosphate. Kaya may nakalagay sa figure na glycolysis and then respiration. Okay, so ulitin natin, pag nakapasok ang glucose sa cytosol, eventually makakapag-produce ito ng ATP. Thus, kapag naging ATP, nakapag-produce ng ATP ang glucose inside the cytosol, tataas ang ATP level sa loob ng cytosol. Kaya makikita nyo na may mga ATP na naka-present sa cytosol. Okay, ito yung mga ATP. Take note, class, when there is accumulation of ATP inside the cytosol, that can cause closure of the ATP-sensitive potassium channel. Okay? Magsasara ang ATP-sensitive potassium channel. Kaya may X kayo nakita dyan. Now, kapag nagsara ang ATP-sensitive potassium channel, that prevents efflux of potassium. Napipigilan ang efflux o paglabas ng potassium. Kaya ang effect nun, naiipon, nag-accumulate ang potassium inside the cell. Okay? Nag-accumulate ang potassium inside the cell. Question, what's the charge of potassium? Positive or negative? Okay, positive. So kung positive ang potassium, ano yung effect niya sa loob ng cell based on your learning sa cardiovascular? Nagde-depolarize siya. Okay, nagde-depolarize kasi nagdo-dominate ang cations inside the cell. And pag sinabi natin nag-depolarize, is the cell stimulated or depressed based on your stock knowledge? Is the cell stimulated or depressed pag nag-depolarize? Okay, very good. Nai-stimulate. And continue natin. And through stimulation of the beta cell, that causes opening of another ion channel. And that is the calcium ion channel. Okay, so that causes opening of calcium ion channel. And as a result, calcium ions from the outside, papasok. Okay, papasok. Kaya that makes the beta cell even more activated. And as a result, because of increased intracellular calcium, that promotes the process called exocytosis. That causes the process called exocytosis of the vesicles. Ang vesicles, ito yung mga bilog na nakikita nyo sa figure, and yaan ang storage form ng insulin. So through exocytosis, gagalaw ang vesicles containing insulin, and thus mare-release na ang insulin. At pag na-release na ang insulin, sasama na siya sa blood natin. And insulin is responsible finally for glucose uptake of glucose that are found in the blood. So yan overall ang regulation of insulin secretion. So brief review tayo regarding the steps. Number 1, again, review tayo sa mga steps. Number 1 is glucose uptake by the glucose transporter 2. Number 2 is metabolism of glucose. Next, number 3, due to increased ATP. Due to increased ATP produced through cellular respiration, there is closure of potassium ions or potassium ion channel. Next, number 4, depolarization. Number 5, influx of calcium. Number 6, exocytosis. Okay, number 6, exocytosis. Guys, naintindihan? Okay, so proceed tayo sa next slide. So ito yung reason kung bakit pag marami tayong glucose sa dugo, magse-secrete ang insulin. Kasi glucose itself is a stimulant of insulin secretion. So regarding glucose transporters, again, glucose transporters, we actually have different types of glucose transporters. I told you na ang glucose transporter 2 ay specific sa beta cells ng pancreas and in some areas of the body like the liver, the kidney, and the gut. But hindi lahat ng cells meron nito. Instead, other types of transporters meron sila. So for glucose transporter 1, ito yung common sa mga tissues. Glucose transporter 3 in the kidney, brain, placenta, and other tissues. Glucose transporter 4 naman is found in muscles and adipose cells, and glucose transporter 5 we have in the gut and in the kidney. So tandaan lang dito, ang glucose transporter 1 ang found o makikita sa iba't ibang tissues, majority ng tissues, and glucose transporter 2 sa beta cells. Okay, sa beta cells. Now, ang na-discuss natin by far ay yung process of secretion by the beta cells ng insulin. So kapag na-secrete na ang insulin from the beta cells, what's gonna happen? Diba sabi natin, ang bottom line ng effect ng insulin, anabolic dapat siya. Okay? Bottom line, ang effect dapat niya ay anabolic. So dapat yung mga i-discuss nating effects dito related sa anabolic effect niya, more on storage. So the following are the endocrine effects held by insulin. Number 1, meron siya mga effects in the liver. First is reversal of catabolic features of insulin deficiency. For instance, it is a hormone that can inhibit glycogenolysis. Recalling the term glycogenolysis, that is the process of breaking down glycogen to glucose. Okay, so glycogen to glucose. That is glycogenolysis. So by the action of insulin, this is being blocked. Okay, this is being blocked. Kaya glycogen is being retained as glycogen, which is a large form. Kaya anabolic ang insulin. Next, this agent also inhibits conversion of fatty acids and amino acids into keto acid. As you learned before, keto acids are alternative source of energy. With that being said, madedetect lang ang keto acid sa katawan ng tao kapag excessively fasted siya. Okay, kapag excessively fasted. And usual sources of keto acids are the fatty acids and amino acids. So ang ginagawa ng insulin is pinipigilan niya ang conversion ng fatty acid and amino acid into keto acid again na madedetect during fasted. So hindi siya pwede mangyari kasi ang insulin dapat tuwing busog lang. Okay? And then finally, it inhibits amino acid conversion to glucose. O anong tawag sa process of conversion, if you could still remember? Ano yung process of conversion ng amino acid to glucose? Review tayo. Ang amino acid ba ay isang carbohydrate? Related ba siya sa carbohydrate, ang amino acid? Yes or no? No, very good. Ang amino acid ay kasali sa proteins. Di ba proteins ang amino acid? So ang point dito sa pangatlong effect, conversion of a non-carbohydrate to a carbohydrate. Conversion of a non-carbohydrate to a carbohydrate. O anong tawag sa process na yon? Very good. It's gluconeogenesis. Okay, that is gluconeogenesis. So, ang ibig sabihin natin sa amino acid to glucose, that is gluconeogenesis. So, what does insulin do? It blocks conversion or it blocks gluconeogenesis. So, pag pinigilan natin ang gluconeogenesis, it prevents accumulation of glucose. So, still, it's anabolic. Okay? So anabolic siya. So yan yung mga effect niya, first three effects niya sa liver. What else? Tuloy tayo, dun tayo sa baba. Another effect of insulin, it promotes glucose storage as glycogen. So pinopromote daw niya ang conversion ng glucose to glycogen. Question, anong tawag sa process of glycogen formation from glucose? Anong tawag doon? Usually, anong suffix pag mag-create? Okay, that's right. Di ko alam kung typo lang yun, Ricardo, pero glycogenesis. Okay, glycogenesis. Okay? So again, that's the process called glycogenesis. This is because ang insulin, it can activate glycogen synthase. It can activate glycogen synthase. And mind you, this is the enzyme that is required for glycogenesis. Okay, glycogenesis. On the other hand, it blocks the action of glycogen phosphorylase. Okay, so it blocks the action of glycogen phosphorylase. Ang glycogen phosphorylase naman ay enzyme needed for glycogenolysis. So this is an enzyme needed for glycogenolysis. So you can see that by blocking the phosphorylase enzyme, we prevent breakdown of glycogen. Anabolic pa rin yun, okay? Next effect of insulin, it increases triglyceride synthesis. It increases triglyceride synthesis and very low density lipoprotein formation. Ang purpose of increasing the amount of triglyceride production is for this to be stored in the adipose. Okay? For this to be stored in the adipose. And this would serve as an energy reserve in case na mag-starve ang isang patient. So more on anabolic pa rin siya. Okay? So these are the effects of insulin in the liver. So we have inhibition of glycogenolysis, inhibits ketoacid formation, inhibits gluconeogenesis, promotes glycogenesis, and then promotes triglyceride synthesis or esterification of fatty acids. Next, what about in the muscle? Actually, in the muscle, it's more of protein and glycogen synthesis. In the muscle, there is increased production of proteins because of enhanced amino acid transport and also ribosomal protein synthesis or translation. And just like in the liver, there is enhanced glycogen synthesis or glycogenesis by increasing glucose transport in the muscle and also promoting glycogen synthesis action, which is needed for glycogenesis, and then blocking the action of phosphorylase na kailangan naman, saan kailangan ang phosphorylase? During glycogenolysis. So it's still anabolic. Okay? In the adipose, ang palatandaan lang dyan, enhance triglyceride storage by causing esterification of fatty acids. Okay? By causing esterification of fatty acids. Overall, these are the endocrine effects brought about by insulin. You can see that insulin has direct effects in the liver, in the muscle, and in the adipose tissues. Okay? And more on anabolic siya. Okay? More on anabolic effect siya. So overall, that's the end of insulin. Ulitin natin, insulin, anabolic, at during fed. Dun tayo sa kabaliktaran ng insulin. Pwede na ba tayo mag-start kay glucagon? Okay, so proceed tayo kay glucagon. Based on your learning or stock knowledge, kailan nase-secrete ang glucagon? Pag gutom o busog? Pag busog ba tayo or gutom? Okay, so pag gutom tayo. And anong klaseng cells ng islets ang nagse-secrete ng glucagon? These are the alpha cells. Okay, these are the alpha cells. And i-explain natin dito bakit siya kailangan pag tayo ay gutom. Siyempre, pag gutom tayo, it is expected na mababa ang blood glucose. Glucose is essential for survival. So, kapag walang compensatory mechanism ang katawan natin in increasing blood sugar, mamamatay tayo. That is where glucagon comes into play. This is synthesized by the alpha cells of the islets of Langerhans, responsible for increasing blood glucose level. So, it increases blood glucose level. So, usually, ang actions ng glucagon ay catabolic. Okay? Yung action niya ay catabolic. Catabolic because we want to extract glucose from larger sources. That's why you can see in the slide that glucagon will activate gluconeogenesis. Okay? Gluconeogenesis. In gluconeogenesis, we tend to convert a non-carbohydrate source to a carbohydrate, particularly glucose. So ano ba yung mga usual sources ng non-carbohydrate para maging glucose? Halimbawa, papasok dyan ang amino acids. Anong tawag natin sa mga amino acids na nagiging glucose eventually through gluconeogenesis? Mga glucogenic amino acids. Ito ulit yon, okay? So again, we have the glucogenic amino acids. And aside from glucogenic amino acids, we also have pyruvate, okay? Pyruvate. Ang pyruvate ay pwede rin maging source para makagawa tayo ng glucose through gluconeogenesis. And then we have lactate. Okay, lactate na product ng anaerobic respiration. And then we have glycerol. Okay, and then we have glycerol. I repeat, for the substrates of gluconeogenesis, we have amino acids, pyruvate, lactate, and glycerol. Okay, that's good. Next, after that, it also activates glycogenolysis. Question, ano nga ulit ang process of glycogenolysis? That is conversion of glycogen to glucose. Okay, so that is conversion of glycogen to glucose. Glucagon activates that process. Okay, activates that process. So when we say activation of glycogenolysis, na-break down, nakakatabolize ang glycogen na large molecule into segments glucose na magagamit natin for survival or energy. Okay? Kaya important ang glucagon for glycogenolysis. So kung glycogenolysis ang ina-activate niya, anong enzyme ang ina-activate niya? Therefore, is it glycogen synthase o phosphorylase? What does it activate? Phosphorylase or synthase? Okay, so it activates the enzyme glycogen phosphorylase. Okay, glycogen phosphorylase. And then, glucagon also increases hepatic glucose production. By enhancing hepatic glucose production, apparently there is increased blood glucose level. We will survive. Okay, ma-overcome natin ang fasting, okay, o yung taggutom. These are the effects of glucagon. So far, class, we were able to discuss the physiological effects of glucagon and insulin. To summarize the role of insulin and glucagon in glucose regulation, ito yung figure that would explain that. Number one, when healthy individuals are hyperglycemic, usually ang hyperglycemic individuals, yung mga healthy hyperglycemic individuals, they are busog, ay fed. Kaya ang goal, yung blood glucose na sobra sa dugo itago sa iba't ibang parts ng katawan. Kaya insulin comes into play. Okay? Kaya insulin ang i-stimulate ang secretion from the beta cells. And increased insulin would tell us na may enhanced glucose uptake and then may utilize siya for anabolic purpose. Anabolic purpose. Okay? What about during hypoglycemic state? Normally, during hypoglycemia, the body will prevent secretion of insulin. Instead, the one that would increase in terms of release ay glucagon. Kaya may arrow up sa glucagon sa slide na to during hypoglycemia. And ang purpose ng glucagon release is catabolic. Kaya ang glycogen stores ay mabre-break down into glucose, kaya may enhance hepatic glucose output that would be circulated in different parts of the body, thus compensating low blood glucose level. Okay? Overall, these are the effects of insulin and glucagon in normal glucose regulation. So far, naintindihan nyo ang roles ng insulin and glucagon, yung effects nila? Okay, may connect natin siya sa medications later. Okay, so mako-connect natin siya. So far, we were able to discuss insulin and also glucagon. But let me tell you na meron din tayo mga miscellaneous important endocrine hormones in sugar or blood sugar regulation. Like for instance, the GLP and also GIP. Nabanggit natin kanina ang GLP at GIP ay mga incretins. They are incretins. Pag sinabi nating incretin, actually may palatandaan dito, incretin, incretin. Yan yung palatandaan natin. I-breakdown nyo lang yung term and then may extract natin ang general action nila. Ang general action ng mga glucagon-like peptides and GIP, they can increase secretion of insulin. Okay? So incretin sila, again, incretin because they can increase secretion, they can increase insulin secretion. So these are potent stimulant of insulin synthesis and release, like what I said a while ago, and enhance beta cell mass. Beta cells are the ones responsible for insulin synthesis and release. Therefore, if there is enhanced amount of beta cells, more insulin will be produced and released. Okay? In addition, glucagon also inhibits glucagon secretion. Okay? So GLPs, they inhibit glucagon secretion and slows gastric emptying time. That's why meron din silang satiety effect. Okay? That's why meron din silang satiety effect. Pag sinabi kasi nating slowing down gastric emptying time, in other words, yung kinakain mo ang tagal ng pagbaba, ang tagal bumaba nung kinain mo, na i-stagnate lang siya sa stomach. Siyempre, pag naiipon sa stomach, you feel busog. Hindi ka makapag-entertain, makapag-accommodate ng other food na i-intake mo. So, meron din siyang satiety effect. And meron din siyang anorexic effect, suppressing you from eating. Okay? Suppressing you from eating. And since ang glucagon-like peptide ay sinusuportahan ang action ng insulin, we realize that glucagon-like peptides or the incretins are hypoglycemics. Okay? They are hypoglycemic hormones. Okay? They are hypoglycemic. That's why sila ay nagpo-provide ng potential therapeutic agent for type 2 diabetes mellitus. And in fact, meron tayong commercially available drug. Again, meron tayong commercially available agent na analog ng glucagon-like peptide. And that is exenatide. Okay, that is exenatide. So we will discuss exenatide later, but I guess meron na kayong idea how it acts based on the effects of GLP that we mentioned ngayon lang. Okay? So yan ang glucagon-like peptides and also glucose-dependent insulinotropic peptide. Moving forward with the lecture, since you were able to understand somehow how the body regulates or maintains normal blood glucose level, paano kapag hindi na na-maintain ng katawan ang normal regulation? Of course, disease could happen. And the metabolic disorder, again, metabolic disorder related to inability of the body to normalize blood glucose level is called diabetes mellitus. This is defined as an elevated blood glucose associated with the following. Number one, there could be absence of insulin release from the pancreas. Again, number one, there could be absence of insulin release from the pancreas. So try to analyze kapag may absence of insulin release from the pancreas, walang hormone, again, walang hormone responsible for glucose uptake o walang hormone ang may kakayahang magtago ng blood glucose or magtago ng blood glucose. So with that, naiipon sa blood. Kaya pwede magkaroon ng diabetes mellitus. Okay? What else? Pwede rin naman na magkaroon ng impairment sa insulin action. Impairment because insulin receptors are resistant. Okay, so again, ang insulin receptors are said to be resistant. Meaning to say, even insulin molecules are being secreted by the beta cells, it cannot be accepted by the receptors. So pag walang receptor binding, walang effect. Yung mga diniscuss ko kaninang effect sa liver, yung mga diniscuss kong effect sa liver, sa muscle at sa adipose, hindi pa rin siya mangyayari. Even masikrit. Kasi receptors, they reject the insulin. Okay? They reject insulin. So yan ang diabetes mellitus. As regarded, we have 4 categories of diabetes mellitus. So let's discuss them individually. Starting off with type 1. Ang type 1 diabetes mellitus is also known as insulin-dependent diabetes mellitus. Okay, this is also known as insulin-dependent diabetes mellitus. And this is characterized by an absolute lack of insulin. Okay, so this is characterized by an absolute lack of insulin. In Tagalog, kulang talaga ng insulin ang katawan pag may type 1 DM. Why? Again, bakit? Because in type 1 DM, this is an autoimmune disease characterized by destruction of beta cells. Okay? This is characterized by destruction of beta cells. And destruction of beta cells would tell us na wala na tayong cell na gagawa ng insulin. Kasi beta cells ang kayang gumawa sa buong katawan eh. So pag destroyed sila, no cells anymore that could produce insulin inside the person's body. Kaya expected na kulang siya ng insulin. Absolutely kulang ng insulin. Okay? That's why patients with type 1 DM, they need replenisher. Pag sinabing replenisher, magbibigay tayo ng gamot na magdadagdag sa kulang. And that is by administering exogenous insulin preparations. Kaya yung mga nakikita nating insulin available in the market, sila ay ginagamit usually in patients with type 1 DM kasi they need exogenous or external source because the ones that produce inside are already destroyed. Nagets ba ang type 1 DM? Okay, next. We also have type 2 diabetes mellitus. Take note, in type 2 diabetes mellitus, there is relative lack of insulin. Okay, there is relative lack of insulin in the body. When we say relative lack of insulin, usually dito sa type 2, there could be normal insulin level, a normal insulin level, meaning to say beta cells are normal. Okay, they are normal. But the problem in type 2 DM are the insulin receptors. Okay, the problem are the insulin receptors in which these are already non-responsive. Okay, these are already non-responsive or they are said to be resistant. Okay, resistant. So I guess na naintindihan na natin yung resistant insulin receptors as I've discussed earlier. Ito yung mga receptors na nire-reject na ang insulin kaya nawawalan nade-defeat ang effect ng insulin kahit pa ma-secrete siya from the beta cells. Next, we have third type, and that is secondary diabetes mellitus. Ay secondary diabetes mellitus type. So pag sinabi nating secondary naman, there is a specific cause why DM emerge to the patient. So meron tayong specific na dahilan bakit nagkaroon ng komplikasyon na DM ang pasyente. For example, when there is surgical removal of the pancreas, common sense, kapag removed ang pancreas ng patient, edi wala nang tagagawa ng insulin. So, may specific cause, may procedure na ginawa. Secondary DM yon. And other related causes like pancreatitis, non-pancreatic diseases, drug therapy, and so on. Okay? And then finally, meron siguro na-encounter nyo to before, we have the so-called gestational diabetes mellitus. Ang gestational ay category number 4. Ay category number 4. Apparently, ang gestational DM happens in pregnant mothers. Okay, pregnant mothers. So the onset of DM in gestational DM starts pag nabuntis siya. So kumbaga, nung hindi pa siya buntis, wala pa siyang DM. Nung nabuntis siya, tsaka siya nagkaroon ng DM. Ang tawag doon, gestational diabetes mellitus. And then after delivery, pag nanganak na siya, mawawala na yung DM niya. Kaya nga, seasonal lang siya. Buong gestational period lang. However, ang disadvantage or possible repercussion ng type 4 DM, ang mga pasyente na may recorded or history ng type 4 DM, they are associated to increased risk of type 2 DM. So pwede sila magkaroon ng type 2 diabetes mellitus in the future. So pag may history sila ng type 4 DM, kailangan may continuous monitoring na ng blood glucose nila. Kasi chances are magkakaroon sila ng type 2 DM in the future. Okay? So these are the categories of diabetes mellitus. Everyone, review tayo ng mga diniscuss a while ago. How many categories of DM do we have? 4. Okay, very good. 4. Please tell me what type number I will describe. Okay? Number 1, relative lack of insulin. 2, very good. Resistant receptors. Okay. Autoimmune. Very good. Destroyed beta cells. Secondary. Next, pregnant. Okay, very good. So yan yung different categories of diabetes mellitus. Are you learning so far? Okay, sa mga taga Makati, okay lang kayo dyan? Meron pa ba? O tayo-tayo na lang nandito? So anyway, let's now proceed on the drugs. So dito i-discuss na natin ang mga pharmacological agents na ang goal ay i-normalize ang increased blood glucose level. By the way, with regards to the diagnostic test or the normal blood glucose level, don't worry because you will encounter those numbers in clinical pharmacy. Okay? Focus tayo sa drugs here. So we categorize anti-diabetic agents into 2 major groups. Number 1 is insulin, which is basically ginagamit sa type 1 DM as a replenishing agent. And then we have the OHAs. We have oral hypoglycemic agents. Starting off with insulin, na-discuss ko na actually ang effects ng insulin, i-review lang natin. Huwag niyong kakalimutan na ang insulin ay may direct effects sa 3 sites ng katawan. These are the liver, the adipocytes or the adipose cells, and in the muscle or in the skeletal muscles as we tell. So again, we have the liver, in the fat, and in the muscle. You can actually review the table that I provided a while ago regarding the effects of insulin. Pero i-recall lang natin. Okay? More on anabolic nga ang effect ng insulin. As much as possible, itatago ng insulin ang excess blood glucose. Itatago niya ang excess blood glucose. It facilitates glucose uptake in these areas and therefore enhancing anabolic reactions like for example, glycogenesis in the liver, and in the muscle may glycogenesis. In the fat, may esterification ng fatty acids forming triglycerides, and other related anabolic reactions. Okay? So yun yung ginagawa ng insulin. So that's why in patients, for instance, with type 1 DM, we need external source of insulin that would be injected to them. Otherwise, pwede silang mamatay because of excess blood glucose level. Based on duration of action, we have three classifications of insulin preparations. Again, based on duration of action. Number one, we have rapid-acting insulin preparations. Tandaan ang rapid-acting, kaya sila tinawag na rapid-acting because the onset of action is fast. Okay? The onset of action is fast or brief. Okay? Meron siyang brief onset of action or fast onset of action. Examples are insulin lispro, aspart, and glulicin. Okay? These are the examples of rapid-acting insulin preparations. Next, short-acting, we only have one example, that is the regular insulin preparation. As per regular insulin preparation, take note that this is the only insulin preparation that is administered intravenously. Okay, again, this is the only insulin preparation that is being administered intravenously. What do we mean by that? Kaya anong ibig sabihin natin? Siguro may idea kayo na ang common route of admin ng insulin ay subcutaneous. Di ba? Ang general route of administration is subcutaneous. Ang exception to the rule doon, si regular. Kasi IV siya. And then, we have intermediate and long-acting insulin preparation. Ang intermediate acting ay si NPH, okay? NPH. Ang NPH ay tinatawag din na neutral protamine hagedorn. Okay? Again, neutral protamine. Okay? This is also known as neutral protamine hagedorn insulin or isophane. Okay? This is also known as isophane insulin. Again, we have neutral protamine hagedorn and isophane. ISO, then PHANE. Okay? Isophane insulin. And for insulin glargine and detemir, again, insulin glargine and detemir, these are the long-acting insulin preparations. Okay? Long-acting insulin preparations. So as per long-acting insulin preparations, they have delayed onset. Okay? They have delayed onset. Okay? They have delayed onset of action. But ang kanilang duration of action, makikita natin na long-acting kasi sila ay nagpo-provide ng effect ng buong araw, buong 24 hours. Kaya nagfa-facilitate ng once-a-day administration lang sa mga long-acting kasi matagal sila sa katawan. Kaya lang ang disadvantage nga, again, ang disadvantage, they have delayed onset of action. By the way, anong ibig sabihin ng fast onset tsaka delayed onset? Anong ibig sabihin yan? Ha? Anong meaning ng onset time? Di ba sa kinetics may onset time? Anong meaning ng onset time? Anong pinagkaiba ng onset sa duration of action? Anong pinagkaiba niyan? Okay, ang onset time is the starting time that the drug is effective. Okay? So ang rapid acting, kaya siya tinawag na rapid acting kasi saglit lang may effect na siya. Pero ang duration niya mabilis. Ito yung mga gamot na ang bilis umepekto, mabilis din mawala. Okay? So kumbaga sa mga nagpapapansin, sila yung grabe magpapansin pero nang go-ghost bigla. Okay? Mga rapid acting yon. Sa umpisa lang magaling, tas aalis na agad sila. Okay? So yun yon. Kapag naman delayed onset of action, matagal maramdaman yung effect pero long-term siya or pangmatagalan. So may investment na kailangan. Okay? So yan ang mga classifications based on duration of drug action. Now, let us emphasize insulin glargine here. Again, let us emphasize insulin glargine. Please note that insulin glargine is the peakless insulin. Okay? Ito ay tinatawag na peakless insulin. So when we say peakless insulin, pag chinek natin ang amount niya in the blood, hindi siya ganun tumataas, constant lang yung amount niya hanggang mag-wear off yung effect niya. Okay? So para mas maintindihan natin yung mga sinasabi ko regarding the onset, the duration, and peakless, let's have this figure. Okay? This figure explains the effect of the different classifications of insulin. And then you can see here na ang y-axis, it represents glucose infusion rate, a glucose infusion rate. And then ang x-axis naman ay time. Mag-focus tayo sa time. Mag-focus tayo sa time. You can see that for insulin lispro, aspart, and glulicin that are rapid acting, for about 1 to 2 hours, I guess, 1 to 2 hours, maximal agad ang effect niya. Maximal agad ang effect niya. So you can see na siya ay merong brief onset of action. Unlike ng ibang classes like detemir and glargine, it takes for about 5 hours o kaya 7 or 6 hours bago maging observable ang kanilang hypoglycemic effect. Kaya nga, rapid-acting ang lispro, aspart, and glulicin. These are long-acting with delayed onset of action. Okay? And then, ang duration of action naman nila, for example, kay rapid-acting nga, kay lispro, aspart, glulicin, kay regular, at kay intermediate acting, hindi siya ganun kahaba as compared sa mga long-acting, okay? Like insulin, detemir, and glargine. And finally, when you check insulin glargine, anong sabi natin sa graph ng insulin glargine? Nagpi-peak ba siya? Diba? No. Okay, no. So peakless insulin siya. You can actually see in the graph na ang insulin glargine ay halos plateau ang na-establish na graph. Halos plateau kasi it is constant or yun nga, peakless, a peakless insulin. So this table enlists the preparations of insulin available in the USA. Some here are available in the Philippines, some are not. Okay? So for rapid acting, we have lispro, aspart, glulicin. And then for short acting, we have regular insulin preparations. Then we have intermediate acting, the isophanes, and then long acting, we have detemir and glargine. Now, in this table, we can see the premixed insulins. So ang premixed insulins ay combination or mixing of either rapid, short, or intermediate. Minsan pinaghahalo sila, okay? But hindi sinasama sa mixed insulin preparations ang long-acting. They are not included. Solely given lang sila. Si insulin, detemir, o kaya si glargine. Okay? Anong reason kung bakit nagpe-premix tayo ng mga insulin preparations? Halimbawa, kay NPH. You can see in the figure earlier na ang NPH, meron din siyang quite delayed onset of action. Unlike ng regular and also rapid acting, may fast onset sila. So in other words, ang goal of combining is para mag-provide ng rapid onset of action, and somehow maprolong ng kaunti ang duration. Okay? Kaya pinagko-combine. But again, accordingly, ang long-acting, they are not being combined or they are not being incorporated with premixed insulin preparations. Okay? So yan ang mga classifications ng insulin. Na-discuss na natin so far ang effects ng insulin, kung bakit siya nakakapagpababa ng blood glucose level, and ano yung mga classifications. Usually for type 1 DM ang insulin. So let's proceed on the possible complications during insulin therapy, yung mga adverse effects. Of course, you knew that insulin can cause hypoglycemia, kaya extension effect of insulin can result to hypoglycemia. So the following are the effects caused by hypoglycemia during insulin therapy. So kung may kakilala kayo nag-undergo ng insulin therapy, they are at risk for hypoglycemia always. And ito yung mga nararamdaman nila. Number 1, merong sympathetic effects, tachycardia, and palpitation. Pansin nyo sa mga kakilala nyo, pag sila ay hina-hypoglycemia, sila ay nagpapalpitate at mabilis tumibok ang puso. And nagpapawis sila and nanginginig. Di ba common yun, yung nanginginig? And then, parasympathetic, nausea or nasusuka, and then hunger, nagugutom. Guys, wag natin ipagsawalang bahala ang hypoglycemic effect ng insulin kasi kapag hindi natin to na-address right away, pwedeng malose ang consciousness ng tao. And loss of consciousness could eventually lead to coma and death. Pwedeng ikamatay. Kaya pansin nyo sa mga taong may DM at nag-i-insulin, anong sinasabi lagi ng doktor? O kahit sa ka pumunta ha, magdala ka ng candy. Familiar ba kayo dun sa counseling na ganon kapag insulin? Dapat magdala ka ng candy ha. Dapat may pagkain ka laging dala kasi madali ka magugutom. Ang candy, meron siyang immediate source ng glucose, kaya mapapataas. O kaya soft drinks, common din yon. Mas madali magbigay ng candy at soft drinks kasi by mouth lang yon. Pero isipin natin, kapag nawalan ng malay ang patient, nag-convulsion at nawalan ng malay, paano mo mapapakain ng candy yung tao? Siyempre, hindi mo na pwedeng gawin yon. So, mas risky siya. Signifying that the patient has kailangan siyang dalhin sa ospital. And pag sa ospital, syempre, kailangan na ng glucose administration. So, mas magastos na siya. Kaya kailangan i-advise natin ang mga patients na magbaon lagi ng candy. Okay? So, hypoglycemia. So, ano pa yung possible na effect ng insulin? We have, by the way, meron akong side story dito sa hypoglycemia. Alam nyo ba na ang pagkalasing ay nagkukos ng hypoglycemia? Ethanol causes hypoglycemia. And if you have alcohol intoxication, you may die. Pwede ka mamatay. Ito yung mga sinasabi natin minsan na lasing siya, nakatulog siya, tapos di na nagising. Totoo yun because of hypoglycemic effect. In fact, my uncle, he died New Year's Eve, 2015. December 31, 2015, kasi medyo lasinggero yung tito ko, tapos nakatulog siya. Tapos di na siya nagising. 11 p.m. ang estimated time of death niya. So nung New Year mismo ng 2016, tahimik lang kami kasi yung kapitbahay namin, tito ko, kapatid ng mama ko, namatay siya because of that. So nung chinek, it's because of excessive alcohol intake, resulting to hypoglycemia and coma. Next, what are the other complications of insulin therapy? We also have immune responses like insulin allergy resulting to localized urticaria. Halimbawa, ng localized urticaria, yung site of injection, kasi injectable siya, di ba? So there could be localized urticaria, and worse, there could be systemic urticaria because of insulin release, okay? Because of histamine release. And aside from that, there could also be insulin resistance in which the body produces antibodies against insulin that could result to lupus erythematosus. And finally, there could also be effect in the site of injection. Ito, common ito na side effect ng insulin. There could be lipodystrophy. Lipodystrophy is atrophy of subcutaneous fatty tissue at the site of injection. Recall that the route of admin for insulin in general is subcutaneous. So pag subcutaneous siya, more on sa fatty tissues ito na pupunta. And take note, pag isang site lang ng katawan, halimbawa sa legs mo lang siya tinuturok from time to time, so kapag sa legs lang lagi, chances are, pwedeng mawala or matapyas, magkaroon ng, hindi ko sure kung familiar kayo sa Tagalog term na to, magkaroon ng lalim, maging uneven yung area ng balat mo kung saan mo tinuturok yung insulin. Kaya pwede magkaroon ng lipodystrophy. So ang advice dito usually ng doctors and pharmacists, kapag mag-administer ng insulin, alternating sites. So for example, sa tagiliran mo, o dito sa bandang left abdomen, kung isang dose ay sa left, sa susunod na dose sa right naman. And then sa left leg halimbawa, and then sa right leg naman. And then i-rotate mo lang yon. Hindi pwedeng sa isang site lang kasi magiging uneven yung part ng balat mo na yon because of atrophy of fatty tissues. Ang tawag doon ay lipodystrophy. So in other words, ang remedy dito ay inject at alternating sites, okay, sa iba't ibang mga sites. O i-rotate mo ang injection. Taken all together, that is the end of insulin. Okay, so tapos na tayo class sa insulin preparations. I repeat, insulin preparations are being used for type 1 usually because we need replenishment already because of destroyed beta cells. So moving forward, pwede na ba tayo sa second group which are OHAs? Pwede na sa OHA? Okay. So second group of anti-diabetic agents are the oral hypoglycemics. Obviously, ang tawag natin ay oral hypoglycemics. So these are administered by mouth. Okay? These are administered by mouth. And generally speaking, these agents are effective for type 2 diabetes mellitus, wherein there is insulin receptor resistance. Okay? And then, marami tayong mga may encounter na drugs under oral hypoglycemics. First group are the insulin secretagogues. Under insulin secretagogues, we have sulfonylureas, Meglitinide group, and then D-phenylalanine derivative. For sulfonylureas, we have two generations. These are first and second generation. For the specific examples, we will encounter them later. Also, we have Biguanides. For Biguanides, ang currently available agent ay si Metformin. You are familiar with Metformin, I suppose. We also have Thiazolidinediones such as rosiglitazone and pioglitazone, alpha-glucosidase inhibitors like acarbose, miglitol, and pakiadd voglibose. Okay, voglibose. So examples of alpha-glucosidase inhibitors are acarbose, miglitol, and voglibose. We also have DPP4 inhibitors or dipeptidyl peptidase inhibitors. Ito naman yung mga drugs ending in gliptin. Maraming examples ng gliptins, okay? But as long as makita nyo ang dulo ay gliptin, automatic yung DPP4 inhibitor na siya. And then finally, we have the glucagon-like peptide 1 analog exenatide. Ang exenatide ang exception to the rule in terms of the term OHA kasi ang exenatide ay sub-Q administered. Okay? So siya yung exception to the rule kasi subcutaneously administered siya. Pero the thing here is, it is used for type 2 DM. Okay? It is used for type 2 DM. Kaya nilagay natin siya dito sa group, sa second group. So this figure summarizes or gives us the overview of the mechanisms of action of oral hypoglycemic agents. So iisa-isahin natin itong i-discuss. So we will start with insulin secretagogues, followed by Biguanides. Third, we have Thiazolidinediones. And then we have alpha-glucosidase inhibitors. And then exenatide. And then meron tayong newer agent na madidiscuss mamaya. So at this point, let us start discussing the mechanism of action of sulfonylureas. Actually, ang topic natin ay mga MOA at mga effects ng insulin secretagogues. Okay, so ang topic natin ay about insulin secretagogues. Everyone, kilalanin muna natin ang term na insulin secretagogue. As the term suggests, insulin secretagogues are drugs that can promote release of insulin from the beta cells. Ito yung mga gamot na ang gagawin, paramihin ang labas ng insulin from the beta cells. So pag maraming insulin, again, pag maraming insulin na secrete, of course, there will be more available for hypoglycemic effect. Kaya ang mga insulin secretagogues ay hypoglycemic agents. Okay, that's why ang mga insulin secretagogues, these are said to be hypoglycemic agents. So ngayon, ang question is, bakit dumadami ang release ng insulin at marami ang nakikita sa blood? Ipaliwanag natin ang mechanism of action. This is actually related to my lecture on regulation of release of insulin kanina. Basically, ang sulfonylureas, they are potassium channel blockers. Okay, again, basically, ang sulfonylureas, they are potassium channel blockers. So apparently, meron na kayong idea what's gonna happen here. Nabanggit natin na kapag na-block ang potassium channel, ang ATP-sensitive potassium channel, that can cause what? Taas or baba intracellular potassium. Ano mangyayari? Pag na-block ang potassium channel, taas or baba ang intracellular potassium? Ha? Okay, taas. And increase in potassium inside can cause what? Hyperpolarization or depolarization? Okay, depolarization. And depolarization can cause increase inward conductance of calcium ions, at pag dumami ang calcium ions inside the cell, that can finally result to exocytosis of insulin. So pag nagkaroon ng exocytosis of insulin, na-secrete mo ang insulin. Okay, na-secrete mo siya. Kaya maraming insulin responsible for glucose uptake, lowering blood glucose, resulting to hypoglycemia. Kaya ang sulfonylureas, they are hypoglycemic agents. Did you get the MOA? Okay, they are potassium channel blockers. So the following are the examples of sulfonylureas. As you remember a while ago, we have two generations of sulfonylureas. Okay, we have two generations, the first and the second generation. So meron tayong concept na dapat matandaan regarding the first and the second generation in terms of their potency and then side effect. Okay? Tandaan for the generation, the higher the generation, okay, the higher the generation, the more potent, but the lesser the side effects. Okay? Again, the higher the generation, the greater the potency, and then the lesser the side effect. Pag sinabi nating the greater the potency, this tells us that the dose preparation available for second generation ay mababa. Di ba, the lower the dose, the more potent. So pag mas mababa ang dose available, mas potent siya. Kaya we realize here that second generation have lesser dose preparation available. So ano yung mga examples natin ng first at second generation? So let's draw a line. Ang first generation ay nasa taas. Okay? So we have tolbutamide, tolazamide, chlorpropramide, and kindly add another example of a first generation is acetohexamide. Okay? Another example is acetohexamide. So these are the examples of first generation sulfonylureas. And for the second generation, ang palatandaan natin sa mga examples, siguro when you had other subjects before, may napansin kayo na yung mga letter G na gamot, mga anti-diabetics. That's correct. So palatandaan, pag second generation, ito yung mga G na gamot. Okay? G na anti-diabetics. Like for example, glibenclamide, glipizide, gliclazide, gliburide, and so on. Okay? So yan yung mga examples natin ng mga second generation sulfonylureas. So for the other characteristics of the generations, for tolbutamide as the first gen, this is accordingly safest sulfonylurea in elderly patients, in elderly diabetics. And ang chlorpropramide naman is usually contraindicated to hepatic and renally insufficient patients and in elderly patients because of prolonged hypoglycemic reactions. Okay? Prolonged hypoglycemic reactions. Ang reason kung bakit ang tolbutamide, again, ang reason kung bakit ang tolbutamide ay safest in elderly kasi ang duration niya ay mabilis, ay short duration. Di ba sa kinetics, the shorter the duration, the safer. Kaya siya ang nire-recommend for elderly patients. And then for second generation, this is being used in caution with cardiovascular diseases and elderly patients, but relatively they are safer as compared to the first gen. And as we remember, these are the Gs, ay anti-diabetics na merong letter G sa starting letter nila. So these are sulfonylureas. Okay? Next, after natin sa sulfonylureas, we also have other insulin secretagogues as we introduced earlier. So meron pa tayong dalawang natitirang insulin secretagogues. These are meglitinide and D-phenylalanine derivative. Ang example natin ng meglitinide ay si repaglinide. Okay? This is meglitinide. Okay? Meglitinide group. And nateglinide naman is D-phenylalanine derivative. So for repaglinide, example is meglitinide. And for for meglitinide, the example is repaglinide. And then for D-phenylalanine derivative, that is nateglinide. Medyo madali ang MOA kasi ang MOA nila, they are also potassium channel blockers like sulfonylureas. With that being said, we infer that they can promote release of insulin ulit. Kasi they can cause depolarization of beta cells, causing increased inward conductance of calcium, thus promoting exocytosis of insulin granules. Okay? So yan ang MOA nila. So yun na nga, na-discuss ko na, potassium channel blockers sila. That's why they can enhance insulin release. So nakalagay regulating potassium efflux, so binablock, and tinitake siya before meal. Okay, before meal. And then, for nateglinide, which is a D-phenylalanine derivative, actually halos parehas lang, ingested before meals din ang nateglinide, which is a D-phenylalanine derivative. So nakalagay, closure of ATP-sensitive potassium channel, so causing depolarization. Okay? So taken all together, that is the end of insulin secretagogues. O guys, review tayo ng insulin secretagogues. Ang insulin secretagogues ay mga gamot na nag-e-enhance ng release of insulin. So we have three groups. Number 1, sulfonylureas. Number 2, we have meglitinide. And number 3, D-phenylalanine derivative. So yan ang mga examples. Now, dun tayo sa common toxicity associated with them. Okay? Common toxicity. Number 1, since these are OHAs, syempre they enhance release of insulin. Chances are, pag extended ang effect nila, pwede mag-cause ng hypoglycemia. Okay? So pwede silang mag-induce ng hypoglycemia. And this is attributable to the drug's mechanism of action. Okay? Attributable siya sa drug's mechanism of action. What else? Ano pa kaya sa tingin nyo ang isa pang toxic effect nila? So this has something to do with your body weight. Okay? So this has something to do with your body weight. Sa tingin nyo, pag gumamit ng insulin secretagogues like nateglinide, repaglinide, and sulfonylureas, what's gonna happen? Weight loss or weight gain? What do you think? Ha? Anong effect? Is it loss or gain? What about the others? What do you think? Hoy, baka mamaya away from keyboard kayo ha. Naka-play lang yan ha. Oh, ano, loss or gain? O sige, gag-guide ko kayo ha. I'm not telling na mali yung gain. I'm not telling also na mali yung loss. O check natin kung magbabago yung sagot nyo. O si Ricardo, persistent gain daw. Inulit niya pa. O tignan natin. Okay. Anong pinaparami ng insulin? Anong pinaparami ng insulin secretagogues? Anong pinapalabas nila? Insulin. Very good. Anong insulin? Catabolic or anabolic? Okay, anabolic. Pag sinabing anabolic, ginagamit o tinatago? Okay, tinatago. Pag tinatago, pwede bang itago ang excess glucose in the form of triglycerides? Yes. Ang triglyceride ba ay nagsisilbing taba sa adipose? So anong sagot? Weight gain or weight loss? Gain. Very good. So no regrets kay Rain. No regrets kay Rain. So weight gain. Okay, weight gain. Kaya yung mga nagte-take ng insulin secretagogues, tumataba sila. Okay, tumataba. Yan ay effect ng insulin secretagogues. Sa tingin nyo ba, nakalimutan ko sabihin kanina sa insulin, sa tingin nyo ba yung pagturok ng insulin nagkakos din ng weight gain? Yes. Okay, nagkakos din yun ng weight gain. So tandaan nyo ha, insulin can cause weight gain. So yan ang adverse effects caused by insulin secretagogues. Everybody, nagets ba bakit weight gain? Okay, that's good. So it's past 8:30 already. So just like our style before, mag-health break muna tayo ng 5 minutes and then after that, proceed tayo kay Biguanide, particularly kay Metformin. Are you familiar to Metformin? Continuing our lecture, let's proceed on the second group of OHAs. These are the Biguanides. Before, meron tayong dalawang commercially available Biguanides. Aside kay Metformin, we also have Fenformin. Okay, so before, we have two commercially available Biguanides. So these are Metformin and Fenformin. However, ang fenformin was already withdrawn from the market. Okay, this was already withdrawn from the market because it causes lactic acidosis. Okay, because it causes lactic acidosis. Actually, metformin also causes lactic acidosis, but it was observed kay fenformin na mas matindi o mas severe ang effect na lactic acidosis using fenformin. That's why it was withdrawn from the market. That's why siguro ang mapapansin nyo lang na Biguanide commercially available nowadays, metformin. So let's discuss now the mechanism of action of metformin. Actually, ang specific MOA ng metformin ay hindi pa clear, although there are certain propositions or proposals regarding its action. Okay? So ang pinaka-dominant or recognized MOA ng metformin is by activating a certain enzyme, and that is the AMPK. So this agent activates the enzyme called AMPK. When we say AMPK, it stands for AMP activated protein kinase. Again, it stands for AMP activated protein kinase. So this means AMP activated protein kinase. Metformin activates the enzyme. And this enzyme is found in the liver and also in the skeletal muscle or in the muscle. That's why may direct effect ang metformin both in the liver and also in the muscle. So isa-isahin natin ang effects ng metformin sa bawat site. First, we have in the liver. So in the liver, you can see na maraming possible effects that can be caused by metformin. Number one, metformin can decrease gluconeogenesis. So it can decrease gluconeogenesis, resulting to lesser hepatic glucose output. Okay, so resulting to lesser hepatic glucose output. So pag sinabi nating lesser hepatic glucose output, konti ang mailalabas na glucose ng liver. So that's why pag mababa ang glucose, mababa ang blood glucose eventually. Okay? What else? By activating AMP enzyme, it can also decrease the activity of acetyl-CoA carboxylase enzyme. And by decreasing the activity of acetyl-CoA carboxylase enzyme, there is increased fatty acid oxidation and decreased VLDL synthesis. Moreover, ang activation of AMP is also responsible for decreasing expression of this lipogenic transcription factor. So yung SREPB ay isang lipogenic transcription factor. Okay, lipogenic transcription factor. So I repeat, this is a lipogenic transcription factor which would lower gene expression of lipogenic enzymes. Kaya overall, ang effect ng metformin in the liver, because of these actions, there is decreased fatty liver and increased hepatic insulin sensitivity. Okay, so increased hepatic insulin sensitivity. So these are the effects in the liver. Okay, in the liver. So decreased hepatic glucose output and increased hepatic insulin sensitivity. O doon naman tayo sa effect ng metformin sa muscle. Ang effect ng metformin sa muscle ay enhanced glucose uptake. Okay, enhanced glucose uptake. It means na ang glucose from the blood, okay, ang glucose from the blood ay matatransport papunta sa muscle. Okay, matatransport papunta sa muscle. So pag na-transport ang glucose papuntang muscle by activating the protein kinase enzyme, bababa ang blood glucose. So pag bumaba ang blood glucose, hypoglycemic effect. Okay? So yan ang mechanism of action ng metformin. So may kinalaman nga sa pag-activate ng AMP-activated protein kinase. So next, for the pharmacologic effects of metformin, so nasabi natin, it can reduce hepatic glucose production and output by activating AMP-activated protein kinase. So the following are the effects, although na-discuss na natin yung iba dito earlier. Number one, impairment of gluconeogenesis. Yes, so by inhibiting gluconeogenesis, lesser glucose. Slowing glucose absorption in the GI tract can also be observed. Next is stimulation of glycolysis. So pag na-stimulate ang glycolysis, we utilize glucose eventually. So pag na-utilize ang glucose, bababa ang blood glucose. And then removal of glucose by enhancing uptake into the muscle. And lastly, reduction of glucagon. Reduction of glucagon tells us na less available for hyperglycemia. So therefore, mapapababa nga ang blood glucose. And one distinct feature of metformin is it is a euglycemic agent. When we say euglycemic, it is an anti-diabetic agent that lowers blood glucose into normal level. Kaya nga U means normal. Unlike ng ibang anti-diabetics, kapag may paggamit sa kanila, they can cause hypoglycemia. Pero kay metformin, it does not cause hypoglycemia. It only lowers blood glucose into normal level, not below normal. Okay? Metformin, as per American Diabetes Association, is recommended as the first-line agent in patients with type 2 diabetes mellitus. Kaya common in health centers na binibigay ang metformin kasi maintenance medication siya. The following are the common toxicities of metformin. Usually, ang effect niya ay ma-observe gastrointestinal. First is anorexia. Next is nausea. Also, we have vomiting, abdominal discomfort, and also diarrhea. Since ang metformin ay nagkukos ng anorexia, it can eventually cause weight loss. Okay? So ang metformin ay nagkukos naman ng weight loss. Unlike ng secretagogues, weight gain. Kaya yung iba na medyo may alam sa action ng metformin, actually, yung iba dito, mga pharmacists pa. Yung part ng weight loss program nila, umiinom sila ng metformin. Kasi iniisip nila, euglycemic naman siya. And siya na actually yung anti-diabetic na safest relatively. Okay, relatively. Pero syempre, kailangan pa rin ng doctor consultation dito. Okay, para ma-induce ang weight loss if you want to have that goal. Next are the contraindications. Contraindications, ano yung mga situations na bawal ang metformin? Number 1, patients with renal disease, bawal sa kanila ang metformin. Next, those patients that frequently take alcohol, hepatic disease, and then predisposing to tissue anoxia patients. Next group. Okay, tapos na tayo sa Biguanide. Next, we have Thiazolidinediones. We have 2 commercially available Thiazolidinediones. These are pioglitazone, marketed under the brand name Actos, and then rosiglitazone, marketed under the brand name Avandia. So later, makikita natin ang difference nila lalong-lalo na sa toxicity. Okay? So discuss muna natin ang mechanism of action ng Thiazolidinediones. Kung ang Biguanide kanina, ina-activate ang AMP or yung AMP-activated protein kinase, ang TZDs naman, they can activate PPAR. Okay, PPAR ang ina-activate nila. But in this case, the subtype PPAR na ina-activate ay PPAR gamma. Okay, PPAR gamma. Na-encounter nyo na ang PPAR noon sa dyslipidemia, pero related doon ay alpha PPAR. Ito, PPAR gamma. Okay? So ano yung magiging effect ng thiazolidinediones by activating PPAR gamma? Take note that the target sites of thiazolidinediones are the liver, adipose cells, and muscle. Okay? So liver, adipose cells, and muscle. And by activating PPAR gamma, what's gonna happen? Number 1, in the adipose, again, in the adipose cells, there is modification of gene expression resulting to lesser lipolysis. Pag sinabi nating lesser extent of lipolysis, this means na ang triglyceride, hindi natin siya ma-hydrolyze into a free fatty acid or unesterified fatty acid. So mas na-enhance natin ang stores ng triglyceride sa fats or sa fat cells or adipose. And then, there is also less expression of tumor necrosis factor alpha, leptin, and increased adiponectin. in which all of these effects would enhance insulin receptor sensitivity. Okay? So this would eventually enhance insulin receptor sensitivity. That's why in some references, we call thiazolidinediones as insulin sensitizers. Okay? That's why ang tawag natin sa kanila ay insulin sensitizers, because by activating PPAR gamma, there is enhanced sensitivity of insulin receptors, facilitating action of insulin hormone. So that's why ang nakalagay dyan, they decrease insulin resistance by regulation of genes through activation of PPAR gamma. So that's the mechanism of action of thiazolidinediones. So although thiazolidinediones are highly effective sensitizers, we have numerous toxicities encountered with the use of these agents. Very common is hypoglycemia, most especially if they are being combined with other hypoglycemics like sulfonylureas and insulin. And there could also be cardiovascular adverse effect. Okay, cardiovascular adverse effect. That is heart failure. Now, dito nagkakaroon ng distinction ang dalawang examples. Take note that between pioglitazone and rosiglitazone, higher cardiovascular risk is observed with the use of rosiglitazone. Okay, so higher cardiovascular risk. In fact, ang rosiglitazone, sa label niya, it has a black box warning. Okay? It has a black box warning. So in the USA, meron siyang black box warning. Pag sinabi natin black box warning, ito ay malaking babala sa paggamit ng gamot. Use it at your own risk, kumbaga. Pwede siyang gamitin pero delikado siyang gamitin. Parang gano'n. Okay? So that's why between Pio and Rosi, mas common na pine-prescribe ng doctors, lalo na sa Pilipinas, ang pioglitazone. Okay, mas common siyang nire-recommend. Okay? So yan yung heart failure. And in connection to this, use of thiazolidinediones is contraindicated to patients with heart failure and also patients with edema, patients who are edematous. So contraindicated to patients with heart failure and also patients who are edematous. So yung related sa edema kasi may fluid retention siya. What else? Dose-related weight gain. So may effect sa timbang ang mga anti-diabetic agents. So dapat ma-recognize nyo sino ang nagkakos ng weight loss, weight gain, and so on. Okay? In women, there could be bone fractures and contraindicated to pregnant women and patients with liver disease. So that's the end of thiazolidinediones. So again, natapos natin ang insulin secretagogues, ang Biguanides, and thiazolidinediones. Moving on, we have the alpha-glucosidase inhibitors. Remember, for alpha-glucosidase inhibitors, this include acarbose, voglibose, and miglitol. And miglitol. So these are the examples of alpha-glucosidase inhibitors. Now, i-discuss natin ang mechanism of action ng alpha-glucosidase inhibitors. Everyone, para maintindihan ang MOA ng alpha-glucosidase inhibitors, i-discuss muna natin ang importance ng enzyme alpha-glucosidase. Again, i-discuss muna natin ang importance ng alpha-glucosidase. Mamaya na ang drug. Ang alpha-glucosidase enzyme, this enzyme is important for glucose absorption, for gastrointestinal glucose absorption. That is, via alpha-glucosidase, ang complex carbohydrate, again, ang complex carbohydrate ay nasisimplify into na-co-convert, nakakatalyze into simpler ones, into simpler forms. So ang complex carbohydrate via alpha-glucosidase, nagiging simple siya in terms of the structure. Question, what's the importance? By the way, can you still follow me? Ha? Okay, so what's the importance of simplifying the structure of carbohydrate? Tandaan, pag simple ang structure, absorbable. Okay? Absorbable. Na-absorb ng ating katawan. Nakakapasok sa dugo. So paano siya nangyayari? So for example, in the figure, again, dito tayo sa figure, for instance, in the small intestine, okay, in the small intestine, we have the oligosaccharides that came from the diet. Oligosaccharides are quite complex that cannot be absorbed by the body. Okay? It cannot be absorbed. Thanks to alpha-glucosidase enzyme, okay, thanks to alpha-glucosidase enzyme, these oligosaccharides could be simplified into glucose or monosaccharides. And as we discussed, kapag simple form na siya, absorbable na ba pag simple form? Okay, so absorbable na siya. Kaya makikita nyo, ma-absorb, and as a result, nagkakaroon ng postprandial hyperglycemia. By the way, pag sinabi postprandial after meal, pagkakain mo, syempre, obviously, tataas ang blood glucose. Okay? So yan ang action ng enzyme. So, pag tinarget natin yung enzyme na alpha-glucosidase, may therapeutic value siya. Kaya meron tayong commercially available alpha-glucosidase inhibitors. That is, these agents block simplification of complex carbohydrate. So pag na-block ang pag-simplify ng complex carbohydrate, no monosaccharide, that's why kahit kumain tayo, this complex carbohydrate will not be absorbed. So pag hindi na-absorb, what will happen to postprandial glucose? Taas o baba? Okay, very good. Bababa. Kaya ang alpha-glucosidase inhibitors ay mga anti-diabetic agents. Naintindihan ang MOA ng alpha-glucosidase inhibitors? Okay, so good. So regarding alpha-glucosidase inhibitors, they can reduce post-meal glucose excursions by delaying digestion and also absorption of complex carbohydrates like starch, oligosaccharides, and also disaccharide. But, again, please advise your patients to take the drug at the first bite of each meal. Okay? So it must be taken at the first bite of each meal. Pag sinabi nating first bite of each meal, dapat iinumin ng patient ang alpha-glucosidase inhibitor kasabay ng unang subo ng pagkain. Okay? Kasabay ng unang subo ng pagkain. Medyo gets nyo ba yung logic kung bakit sa unang subo siya iti-take? Or kailangan natin explain? Sa tingin nyo, bakit siya at first bite? Explain natin. Ha? Okay, explain natin. So pag sinabi nating taken at first bite of each meal, dapat sa unang subo ng pagkain, iinumin yung gamot. Bakit? Ang binablock ng alpha-glucosidase inhibitor, yung enzyme na magsisimplify ng sugar. So imagine niyo kung iti-take nyo siya after meal, halimbawa, after meal. Kung after meal nyo siya iinumin, pagkakain nyo, syempre habang kumakain kayo, dinadigest na yung ibang pagkain. Kaya habang dinadigest, active pa rin ang alpha-glucosidase, may na-simplify na carbohydrate even before taking acarbose. So ang point dito, uunahan mo. Gamot muna, block muna yung enzyme, bago sumunod ang pagkain. Para pag dumating yung pagkain, walang available enzyme for simplifying the sugar that you took. Naintindihan ko ba't first bite? Yon, uunahan mo siya, okay? Pag na-miss mo yon, pag kumain ka agad, wala na, absorb na yon, tataas. Hindi na effective yung gamot. Okay, hindi na effective yung gamot. So yan. So for the specific agents, acarbose has a small effect on alpha amylase. And for Meglitol, it is 6 times more potent than acarbose in inhibiting sucrase and effects also in other enzymes like isomaltase. And for combining acarbose and Meglitol, they can target other alpha-glucosidases like sucrase, maltase, glucoamylase, and dextranase. Okay? So for the clinical use of alpha-glucosidase inhibitors, they can be given as monotherapy, meaning isa lang, solo lang, o kaya in combination with sulfonylureas. Okay? In combination with sulfonylureas. Ano ang common adverse effect ng alpha-glucosidase inhibitors, utot ng utot, flatulence. Okay? So ang common adverse effect nito ay flatulence. Meron pala sa slide, sorry, hindi ko nakita. So, ang common adverse effect ay flatulence kasi nga hindi mo na-absorb yung complex carbohydrate. So, para kami lactose intolerance, parang ganun yung dating. Kaya meron ka ring diarrhea, abdominal pain, and chances are hypoglycemia as well, especially when combined with sulfonylureas. Okay? And then, for miglytol and acarbose, these agents are primarily excreted by the kidneys. That's why patients with renal disease should not be given with miglytol and also acarbose. So everybody, we are finished discussing alpha-glucosidase inhibitors. Next stop, we have amylin analog. Okay, amylin analog is pramlintide. Okay, so yung amylin analog ay pramlintide. Na-discuss natin na ang amylin ay isang hormone, siya ay supporter ng insulin. Supporter in a sense na ang effect ng amylin ay may kinalaman o somehow related sa effects ng insulin. Kaya meron tayong gamot like amylin para ma-manage ang diabetes. So usually ang pramlintide ay ina-administer subcutaneous. So another exception siya sa OHA. And this is effective for both type 1 and type 2 diabetes mellitus. And since ito ay similar ng action with insulin, this is usually co-administered to insulin, and its action is by suppressing glucagon release and delays gastric emptying. That's why may satiety effect ulit, as we mentioned earlier, and anorectic effect, or meron siyang anorexia effect. Adverse effects are hypoglycemia, and then gastrointestinal symptoms, nausea, vomiting, and also anorexia. Again, subcutaneously administered siya. Next, we have incretin analog or incretin mimetics. So for incretin mimetics, we have two groups. Again, we have two groups of incretin mimetics. Number one, yung exenatide. Okay, number one, we have exenatide. And aside from exenatide, we have the DPP4 inhibitors. Okay, so again, incretin-based drugs are exenatide, and also we have DPP4 inhibitors. Nabanggit natin na ang incretins ay important because they can enhance secretion of insulin. O recall, what are the examples of incretins? Ano yung mga examples natin ng incretins? Both start with letter G. Ano yung dalawa na yon? Okay, very good. We have insulinotropic peptide. What else? Okay, very good. GLP, glucagon-like peptide. Very good. So first stop kay exenatide. Ang exenatide, ito ay analog ng glucagon-like peptide. Okay, this is an analog of glucagon-like peptide. Hence, the effects that we tackled earlier about GLP-1 would be observed using exenatide. Like for instance, we have potentiation of glucose-mediated insulin secretion. So nai-induce ang insulin secretion from the beta cells. Next, nasusupress ang glucagon release. Meron ding satiety effect. Okay, satiety effect, loss of appetite. Okay, loss of appetite. That's why ang exenatide is being used for type 2 diabetes mellitus. Nabanggit natin ito kanina, pero subcutaneously administered siya, just like pramlintide. This is often combined with metformin, o kaya kapag medyo worse na yung condition, triple combination na. Exenatide, metformin, sulfonylureas. Okay, so that is exenatide. Note everyone na meron pa tayong isang commercially available na GLP analog. Okay, so itong exenatide ay GLP analog ha, GLP analog. So aside from exenatide, another is liraglutide. Okay, so another example is liraglutide. Next are the adverse effects. Usually yung mga effects ng mga anti-diabetic agents, pansin nyo, aside from lowering blood glucose, gastrointestinal. So we have nausea, vomiting, diarrhea. In this case, weight loss, para siyang si metformin. And then chances are there is worse effect like hemorrhagic pancreatitis. Next, mali ako ng title dito. Dapat dito DPP4 inhibitors. Okay, pakibago. DPP4 inhibitors. Again, paki-edit. For another group of incretin-based drugs, we have the DPP4 inhibitors or the dipeptidyl peptidase 4 inhibitors. Okay? So regarding dipeptidyl peptidase 4 inhibitors, nabanggit ko kanina na ito yung mga gamot na nag-e-end sa gliptin. Okay? So no need to enumerate all. Basta excuse me, basta nag-e-end sa gliptin, that's it. Sitagliptin, uh, uh, alogliptin, linagliptin, saksagliptin, yun yung mga examples. So tandaan nyo na lang gliptin. Okay? Nakalagay dyan na they can increase the levels of incretins like glucagon-like peptide 1 and glucose-independent insulinotropic polypeptide. Siguro meron kayong question na may isip dito, Sir, ang MOA nila of course ay DPP4 inhibition. Okay, you are correct with that. They are DPP4 inhibitors. Pero the question here is, anong connect nito sa pagtaas ng incretins? Okay? Ano ang relasyon? So upang magets yun, let us have this illustration. Okay, let us have this illustration. And then babalikan natin yung slide kanina. Para maintindihan ito, i-explain muna natin ang importance ng enzyme, dipeptidyl peptidase 4. Ang dipeptidyl peptidase 4 ay isang enzyme that can destroy, that can inactivate incretins. So through inactivation of incretins, syempre, magkakaroon ng inactive metabolite na hindi na effective or wala ng epekto sa katawan. Ano ba ang importance ng incretins? As we remember, incretins are important because they can increase secretion of insulin. Kaya nakalagay dyan, stimulate insulin release, increase secretion of insulin, incretin, and then they inhibit glucagon release. With these actions held by incretins, there is lowering of blood glucose level. Kaya important ang action ng incretin. Now, because of the enzyme, nawawala ito. Okay? Nawawala yung ganitong effects. Kaya may therapeutic value pag binlock natin ang dipeptidyl peptidase 4 like the gliptins. By blocking DPP4, no inactivation will be observed. That's why, can you tell me what's gonna happen to the incretin levels? Enhanced or reduced? Incretin level, enhanced or reduced? Enhanced. It must be enhanced, okay? So enhance incretin levels. By enhancing incretin levels, do you think may hypoglycemic effect? Or merong anti-diabetic effect? Yes, okay, very good. Kaya nakalagay dito, increase circulating levels of incretins like GLP-1 and GIP. Hence, these agents can decrease postprandial glucose excursions by increasing glucose-mediated insulin secretion. Kasi nga, incretin ang pinaparami nila and decreasing glucagon levels. So, ang use ng DPP4 inhibitors pwedeng as monotherapy or combination with Thiazolidinediones and also Metformin. The following are the adverse effects. Number 1, we have nasopharyngitis. Second is upper respiratory infection, headache, and severe allergic reaction. In terms of weight alteration, somehow, one good thing about the gliptins, in general gliptins, weight neutral sila. Okay, weight neutral. So kung ano man yung timbang mo ngayon, hindi sila directly nakaka-affect. Weight neutral. Neutral. Okay, so these are the adverse effects of the gliptins. So far, okay pa ba kayo? Medyo malapit na matapos. Naintindihan ba yung lecture so far? Okay. So, natapos natin ang mga conventional anti-diabetic agents. O recall tayo ha, ang mga examples ng mga anti-diabetics that we discuss are insulin secretagogues comprising of sulfonylureas, also Meglitinides and phenylalanine derivatives. Kaya nakalagay dyan, they can address impaired glucose secretion. So they can enhance actually. Okay? Next, Biguanide like Metformin, they can decrease, okay? They can decrease or it can decrease hepatic glucose output, and also in the skeletal muscle may affect siya. Na-discuss natin by activating AMP, AMP kinase. Next, for insulin sensitizers, the thiazolidinediones, they activate PPAR gamma. Okay, PPAR gamma. So that's why may effect sila sa liver, sa skeletal muscles, at sa adipose cells. Next, for alpha-glucosidase inhibitors, they can decrease absorption of carbohydrates. Okay, they can decrease absorption of carbohydrates. Now, hindi pinakita sa presentation na to, pero we have others like pramlintide, like the incretin mimetics. Ano yung dalawang groups ng incretin mimetics? Number one, the GLP analog, and then the DPP4 inhibitors. Okay? Yun lahat ang mga typical examples or classes ng anti-diabetics. So moving on, meron tayo, by the way, naintindihan ito lahat, yung summary ng MOA, NFX. Bago tayo mag-continue sa next slide. Okay. Next, meron tayong newer agents, ay bagong anti-diabetics. And these are the SGL2 inhibitors. So first stop, para maintindihan ito, kilalanin muna natin ang SGL2. Ang SGL2 ay isang transporter. And it actually means sodium glucose linked transporter. Okay? So it means sodium glucose linked transporter. Okay? So it means sodium glucose linked transporter. So yan yung meaning ng SGL2. Saan natin makikita ang SGLT2, sorry. Ang SGLT2 is found in the proximal convoluted tubule. Okay? So we can find this in the proximal convoluted tubule. Saan parte ng katawan may PCT? Saan parte ng katawan may proximal convoluted tubule? Okay, in the kidney. Very good. Na-discuss natin yan sa diuretic agents. Okay? So in the proximal convoluted tubule. What's the function of SGLT2? This is responsible for the reabsorption of majority of glucose in the kidneys. So pag meron tayong glucose in the kidneys, normally bumabalik talaga siya sa ating dugo via the sodium glucose transporter. Okay? 90%. So by using sodium glucose transporter inhibitors, yung supposedly reabsorption ng glucose na bablock. Kaya 90% ng nare-reabsorb na-excrete eventually. That's why in the figure, you can see na pag gumamit tayo ng SGLT2 inhibitors, yung 90% glucose reabsorption is being blocked. Hence, enhance ang excretion. So ang ultimate effect ng SGLT2 inhibitors, enhance glucose excretion. Question, kapag enhanced excretion, do you think may hypoglycemic effect? Okay, meron. Kasi napapababa ang blood sugar. Okay? So by inhibiting SGLT2, there is glycosuria. Glycosuria meaning the amount of glucose in the urine is high kasi nga enhanced excretion and lowers blood glucose levels in patients with type 2 diabetes mellitus. So examples are the liflozins, like canagliflozin or gliflozin. So we have canagliflozin, next dapagliflozin and empagliflozin. Okay, so palatandaan gliflozin. So yan ang mga examples. Now, proceed tayo sa adverse effects. Okay? Adverse effects na pwede nating ma-encounter with the use of these agents. Guys, ang point of using these drugs ay pinaparami ang glucose sa ating ihi. Okay, sa ating ihi. Kaya, very important advice that we should give to the patient, ma'am, sir, tuwing iihi po kayo, magsabon po kayo, practice proper hygiene. Kasi pag hindi mo tinaktak na maayos yung ihi sa organ mo, pwedeng ma-stay ang glucose doon sa organ mo or sa ihi na may glucose. Gusto ba ng microorganism ang glucose? Yes. So anong point natin? Prone sa infection ang tao na magte-take ng gamot na to. So common adverse effect is urinary tract infection, okay? Urinary tract infection, and pwede magkaroon ng fungal infection, okay? Fungal infection. So expected na kapag hindi nag-practice ng hygiene yung tao na nagte-take nito, pwede niyang ireklamo na magkaroon siya ng UTI o kaya magkaroon ng fungal infection sa kanyang genitals. Okay? Kaya dapat i-advise natin na practice proper hygiene. Linisin mabuti every time na iihi, hygiene. Naintindihan yung relation ng adverse effect dun sa MOA ng gamot? Okay. So yan ang newer agents natin under OHAS. So overall, tapos na tayo sa mga gamot. So dito tayo sa combination therapy in the management of type 1 and type 2 DM. So first for type 2. Actually, na-discuss na natin ang mga actions sila. So doon na lang tayo sa mga purpose or effect. Mali spelling ng exenatide. Okay, exena. Okay, exenatide and pramlintide. Okay, pramlintide. O, pakibura na lang. So we have exenatide and pramlintide. Usually, exenatide is being combined with biguanides o kaya biguanides plus sulfonylureas or insulin secretagogue. So ang purpose is to enhance the hypoglycemic effect. However, kapag ginamit ito, possible risk is hypoglycemia, directly related to the MOA. Pramlintide is being combined with metformin or sulfonylurea, that is to achieve the target postprandial glucose, yung normal blood glucose level. And insulin, actually insulin can be used for type 2 DM pag worse na yung condition, but hindi siya ginagamit as monotherapy pag type 2. Okay, pag type 2. So often it is being combined with numerous agents, that is to achieve the normal blood glucose level. These are the combination therapies for type 2. Sa type 1 naman, 'di ba sabi natin insulin ang mainstay therapy kapag meron kang type 1 DM. Pero we can combine pramlintide. Ang pramlintide ay isang amylin analog. 'Di ba ang amylin analog or amylin is a hormone co-secreted with insulin kasi halos same sila na action. So by combining it, enhance action of the hormone for type 1 DM. Okay? There are also drugs that are not approved for use in type 1 DM patients. So bawal ang Biguanides, Thiazolidinediones, Alpha-glucosidase inhibitors, Incretin mimetics, and insulin secretagogues. Kaya nabanggit natin, OHAs like this are for type 2. Okay, for type 2. Ang type 1 na pwede lang ay si pramlintide. So overall, that's the end of drugs for diabetes mellitus. Ang ultimate goal is to lower the elevated blood glucose levels. So another topic tayo guys, last topic na to under pancreatic hormones, glucagon. Hindi na to pang DM ha, hindi na to pang DM. Kasi ang trabaho ng glucagon, pataasin ang blood sugar. Okay? Kaya hindi na siya related sa management ng diabetes mellitus. Na-discuss na natin ang mga effects ng glucagon. So it can increase blood glucose level. It can also cause release of insulin from the beta cells but not as significant as compared to the actual effect of insulin. Next, it can also increase catecholamines from pheochromocytoma. Guys, ang release of catecholamines is also essential in causing hyperglycemia. Okay, this is also essential in causing hyperglycemia. Halimbawa, epinephrine. Epinephrine can can induce hyperglycemia. Okay, so it can induce hyperglycemia. Next, release of calcitonin can also be observed with the use of glucagon. Next, cardiac effects. Meron siyang positive inotropic and chronotropic effect by increasing camp levels. Okay, by increasing camp levels. So somehow, meron siyang similar effect with beta agonist. Okay, by increasing camp levels. So pag increase ang camp levels, more calcium will enter in the muscle, kaya greater and faster contraction. And in the smooth muscles, there is relaxation of the intestine. Okay, there is relaxation of the small intestine. So because of these effects brought about by glucagon, it can be used for the different purposes. Number one, hypoglycemia. So alam nyo na to because hyperglycemic effect siya. Next, endocrine diagnosis. For example, in the diagnosis of certain endocrine disorders and in the measurement of C-peptide in indicating beta cell secretion. Kasi nga, siya ay inducer din of insulin release eventually. Okay? Next, radiology or radiology of the bowel. When we say radiology of the bowel, it means kapag gusto nating i-check ang abdomen ng patient, lalo ng intestine, halimbawa x-ray, para magkaroon ng clear view during x-ray sa ating intestines have to be relaxed. Okay? So pag relax ang intestine, okay siya, makikita na maayos. So we can use glucagon kasi remember, its effect in the intestine is relaxation. And finally, it is considered as antidote for beta blocker poisoning. Beta blocker poisoning, meaning may overdosage tayo ng beta blocker. So it is expected na kapag meron tayong overdose ng beta blocker, masyado mababa ang camp sa patient. Anong sabi natin sa action ng glucagon? Does it enhance camp levels? Does it enhance camp levels? Ha? O, hindi na nakikinig kasi huling slide na. O ano? Yes, okay. So it increases camp levels, so mayroong positive inotropic and chronotropic effect. Okay? So yan ang reason kung ba't ginagamit na antidote ang glucagon for beta blocker poisoning. These are the clinical uses and actions of glucagon. So we discussed the effects of glucagon kasi may mga conditions na mababa naman ang blood glucose. So patataasin natin siya and other purposes. Pero yun nga, ang prioritize natin sa chapter na to ay mga anti-diabetics. So from the start up until here, I think we are finished discussing the topic. So double check natin if we were able to accomplish the outline. We finished discussing the pancreas and the hormones secreted by it, insulin, the effects of insulin, regulation of secretion also, glucagon, yes, DM na discuss natin, and categories, yung 4 na categories. Sa drugs, ano yung dalawang groups ang diniscuss natin? Number 1 is discussing insulin, and then collectively we have the OHAS. Okay, we have the OHAS. So based on your attendance mula kanina, agree ba kayo na natapos na natin yung topic? Okay. So overall, that is the end of our